Hi everyone, and hi everyone online as well. Thanks for joining today's lunchtime seminar organising the epidemiology unit. I'm Andy Crawford. I lead on the operational side of Population Research UK. So that's an initiative that aims to maximise the potential of longitudinal population studies across the UK, and that's across social, economic and biomedical research. And so in the UK, we have a sort of unparalleled collection of longitudinal studies, and there's over 240 of them listed in the Atlas of Longitudinal Datasets. Today's speaker is from the very largest of those. I'm delighted to welcome Professor Raghib Ali, who is the CEO, Chief Medical Officer, Chief Investigator, I think, of Our Future Health, which has over 2.5 million participants. And he's also a clinical epidemiologist at the University of Cambridge, researching on the etiology and prevention of communicable diseases, particularly in underrepresented populations. So thank you for coming to Bristol today. We're looking forward to hearing what you have to say.
Thank you. Yeah, no, thanks very much, Andy. So very good to be here. So actually, the time worked out very well because you offered me a range of dates, and one of them was the same day as my son's birthday, who is a student here at Bristol. So thank you for offering today as a day. But no, it's great to be in Bristol when it's not raining as well. So my previous visits here, yeah, it's always been pretty good, and it's great weather. And so as you've heard already, our Future Health is a very large study, and that's the title as well. But it's not as familiar as many other cohorts because it's relatively new. So often when I mean, you're a very well educated audience, of course, so you've probably all heard of it. But often when I speak to conferences, I'd say probably half the people still haven't heard of it because it's only been going for 3.5 years. The data's only really available for 1.5 years. So I hope today I'll be able to give you a helpful kind of status update. I won't speak to the whole hour you'll be relieved here, so there should be plenty of time for questions and discussion at the end. Okay, so in terms of why Our Future Health was set up, really it started from the, in some ways, very difficult public health background that we're facing, or even 5 years, even worse now. I'm sure you would have seen earlier this week the data that the Health Foundation published on healthy life expectancy, which I'll come back to. But some of these issues, of course, have been around for some time with an aging population, increasing multi-morbidity. I think what's changed over the last 10 years are really plateaus in overall life expectancy, decreases in healthy life expectancy, much higher numbers of people being off work of working age populations. And also the inequalities, unfortunately, if anything, have got worse over that time period. Certainly they have not improved. So given that very challenging kind of background, I'll go into a bit more detail on some of those, because I think it is very sobering actually what's happening in the UK. This is the data that was published a couple of days ago by the Health Foundation. So healthy life expectancy, the number of years lived in good health, and there is some subjectivity in this. People are asked about how they would rate their own health, but at the same time, it's the best measure that we have. And with a consistent way of measuring it, you can see a big decrease in healthy life expectancy over the last 10 years across all nations. There's a bit of noise there in Northern Ireland, as you might expect, because it's a smaller population, but I suspect the trend is similar across all nations. And of course, it's mainly driven by England. But yeah, really quite significant drops for both men and women, but actually even more pronounced in women. You continue to have an advantage in overall life expectancy, but in terms of healthy life expectancy, not really anymore. Again, this will be familiar to most of you who work in this field, these huge geographical variations in healthy life expectancy as well, both in males and females. Certain parts of the country which haven't really improved in terms of the life expectancy, have decreased over the last, again, this is looking over the last. Okay, that's fine. It's a good idea, so you can see it over there on that side of the room as well. But there are certain parts of the country I'm saying where, unfortunately, we really have not seen an improvement, either life expectancy and, in this case, reductions in healthy life expectancy, particularly South Wales, Central Belt Scotland, parts of the North East, North West, parts of Northern Ireland. The one area where things have improved actually is London. And I might talk a bit more about that, having lots of questions about why London may be a bit of an outlier in relation to this data. And hopefully for the first time we have a cohort study large and diverse enough to answer some of these questions as to why we see some of these unexplained differences. Most of them are well explained by deprivation, so still a slight echo, but I'm not sure where it's coming from. So most of it is explained by deprivation. That's by far the biggest determinant of healthy life expectancy life. So again, this will be familiar to us. But the gap, unfortunately, has not got less by deprivation. It's actually slightly increased over the last 10 years. I mentioned at the beginning about it's slightly off base, for me at least. Right again.
Is that better?
I think it's okay. Yeah. So I was saying in terms of one of the big changes over the last few years has been the increase in people being unable to work because of poor health. Again, RP12 is really the first cohort ever, which is large enough to look particularly at younger age adults and the impact of poor health on their employment prospects. And we are now seeing people going directly from university, for example, into onto sickness benefit for not being able to work. This is one graph which is illustrating the proportion of 16 to 24-year-olds who are not in education, employment, or training who report having a work-limiting health condition. And again, you can see the numbers there really are quite high as to why people are meat. A lot of it is driven by poor health. And this is a kind of very high-level breakdown of the types of disorders. And of course, some of this is driven, although a minority, by changes in kind of diagnostic thresholds and criteria. But there's a definite increase, particularly in mental health conditions, to them over that time period. Which again, I would say is not very well explained. There are studies, and some of them, of course, are in Bristol itself, where you have large cohorts of young people, or relatively large cohorts of young people. But most studies, historically, including UK Biobank, and actually most large cohorts across the world, have been in the age group 40 plus. That really misses, this age group completely. We're looking forward to, of course, the adolescent health study providing additional data, but that's going to take a few more years to come through. So talk about geography, deprivation, and finally something on ethnicity. But this is where the picture actually is more complex, I would say, than has historically been the case. So for a long time, it was true that most ethnic minorities had worse health outcomes than the majority kind of white population. That's no longer the case, although there are some. Pakistan and Bangladeshis, as the two most deprived populations, as you'd expect, do have higher levels of multi-morbidity, and that fits with a kind of deprivation background. But when you look at mortality from different diseases, we see a very different pattern. And I'm partly going through this in this talk because it's my own area of research before our future health. But I think it is relevant for what we'll be able to investigate in our future as well. So we have green means that whether it's looking at all mortality or the individual causes there, which I won't go through them, that these ethnic groups do better than the white population. Red is obviously where they do worse than amber, where there's no statistically significant difference. And the pattern, as you can see, is very mixed. And I think when this data first came out, people were surprised that in general, ethnic minorities actually do better on most causes of mortality. There's a significant outlier, which is circulatory diseases, which of course is the leading single cause of death, has an impact on overall mortality. But what's particularly surprising is that Pakistanis and Bangladeshis, despite having high levels of deprivation, do not have high levels of mortality. That's really different to what you'd expect given their deprivation. And if you look at more versus less deprived in the UK, it is generally all red. If you look at blacks versus whites in the USA for obvious historic and current reasons as well, again, it's mainly all red. But the picture is more nuanced. And if you look at life expectancy, which is the best kind of overall measure of both social and other determinants of health, we again see that in general, ethnic minorities have better life expectancy and lower overall mortality. And I'm happy to talk more about this in the discussions with people interested. Okay, so all of that was by way of background. Huge public health problems in the UK. Can a new research study help us to understand what's driving those and hopefully tackle them and improve the situation? This is where RP Health came in. So RP Health was established both to help tackle those public health challenges, but also to see if we could change our model of health and healthcare. So I don't know how many people here are medical doctors, but I'm sure some of you are. So as you know, in medicine, we tend to see people who are at the end of this stage, or at the end of the natural history of a disease. In my own background, as a consultant in acute medicine, I spent most of the first half of my career mainly working in hospitals, seeing patients, with heart attacks, strokes, cancers that had already spread, advanced dementia, etc. But towards the end of that process, and I recognised early on, for me personally, that I prefer to spend more time trying to prevent those diseases than treating. That's why I moved more into public health in the second half of my career. So this is not just the current model of care in the UK, but really globally. This model that was put in place, with the advent of the NHS as well. So the NHS is very much set up to treat people with disease, and that's not surprising because that's what you can do for a long time. We're now moving towards the opportunity to have hopefully a better and newer model of care, which is described in different ways: precision public health, precision population health, that's precision health, which is identifying people at high risk earlier, and being able to detect or diagnose disease earlier. And this diagnosis is maybe not the right term. It's really about detecting disease even before you have a formal diagnosis based on clinical criteria, and intervening earlier in that pre-symptomatic phase in order to prevent or at least delay disease. And for many diseases, we don't know how to do this. We do for a few, so diabetes, cardiovascular disease, some cancers, we have a much better idea of natural history, but then for many diseases we don't. For pancreatic cancer, for example, we don't have very good idea certainly of how to prevent it, even until the risk factors. It's not very well understood, even though it's the 10th leading cause of death overall in the UK and the 4th leading cause of cancer mortality. And there are many other examples like that. So there is I would say, an unmet need in terms of understanding how we can intervene or detect disease earlier, find people at high risk earlier, and intervene earlier. And our future health had to be very large. So you'll all be familiar with or most people know that we're trying to recruit 5 million people. It's really to enable us to look at many more diseases than is possible with smaller cohorts. I won't go through this in detail, but again, happy to answer questions on it at the end if there's interest in particular of these technologies. And this is not exhaustive either. I mean, there's a couple which we are planning to look at, and you may have seen in the NHS 10-year plan a specific commitment to work with the NHS on integrated risk scores. So this is where we combine polygenic risk from the DNA that we've collected with other risk factors. So it's fairly well established into how to do this with diseases like cardiovascular disease and diabetes, and to an extent breast cancer, but not so much in other cancers. But the idea is that by being able to identify that currently most of our risk scores don't take into account genetic risk, and that's not that important for some diseases. Say diabetes, we have good way to calculate risk already. Even cardiovascular disease, we have a fairly good risk calculator. But for other diseases like prostate cancer, it may be very important to understand the underlying genetic risk as well. So this is something we'll test. I mean, our future health is a research program, and it's here to really test these new approaches and to see if they do lead to better outcomes and are cost effective. And the only other one I'll mention here is the digital interventions. So again, most interventional studies today have really been on pharmacological interventions. And we want to be able to understand if because now we can deliver interventions much more cost effectively through digital technology, whether they will also help to change people's outcomes using digital interventions. That's a particular area of interest. I'll come back to the screening one. So our future health was established with this very ambitious vision and mission. I won't read through them, but you can see it really is a very ambitious program. Ultimately, what we're trying to achieve is to give the people the opportunity to live longer and healthier lives, by focusing particularly on prevention. And that we are doing through a research program. Of course, in parallel, we hope the Department of Health and the NHS will implement what's already known. But our role is really to identify a new evidence base for new approaches to prevention, early detection, and treatment of disease. It was set up somewhat uniquely, I think, as a public-private partnership. So the initial government funding, which came from Innovate UK and part of the Industrial Talent Strategy Fund, had a condition. So they were giving us £79 million back in 2020. So we just passed our 6th birthday. But the condition for that was to have 160 million given by industry as well, so matched funding. And fortunately, we were able to persuade 16 life sciences companies to give a kind of £10 million each as an upfront contribution, which was relatively high risk, given that I don't think anyone knew. And some of you, maybe Nick and others, would have been familiar with each other quite early on. There was significant doubt as to whether people would take part in the program. So it was a bit of a risk for those companies. A few charities, as you can see, have also contributed now. So particularly Welcome and Life Park, given significant contribution to $10 million each, and then Cancer Research UK, British Life Foundation, that's $7 million. We work with a lot of affiliate charities as well who have, of course, particular interest in different diseases. Okay, so I'm going to go through the 4 kind of central aims of the program, and just to reiterate the point that it really is about establishing a new evidence base. The first was to build the resource. So RPTL is a resource, very similar model to UK Biobank. We don't conduct the research ourselves, although we do some research internally, but the vast majority of research will be done by all of you and researchers across the world, both discovery and translational research. So again, there are some key differences to UK Biobank. The most obvious, of course, is the size and scale, as I'll show diversity of the cohort. But in some ways, more importantly, I'd say it's also the opportunity to do interventional studies and give feedback to participants, which wasn't possible in UK Biobank. So we did make a commitment to our participants, and I hope some of you are participants. I usually ask at the beginning, actually. I forgot today. But I hope some of you are participants. If you're not, then please do join. But yeah, to give people information about their risk of disease for a number of disorders, including or based on both genetic and non-genetic information. And again, Biobank was deliberately set up, and Biobank was actually the first study I worked on back in 2004. And I think rightly so, it was set up in a no feedback cohort, otherwise it would never have happened. It's just wasn't possible to do that at that time. I think for both ethical reasons, but also in terms of establishing the evidence base, we want to show, or to be able to show, whether providing feedback to people does lead to better outcomes, whether people having that information, the difference to diseases, particularly hopefully where there are either screening opportunities or treatments available at the early stage of disease that will lead to better outcomes. Also mentioned here is that risk stratified screening programs. So most of our screening programs, in fact all of them currently, are based on age alone. And we think that we can do better in terms of screening by stratifying people based on all risk factors, including genetic risk. There will be some people, for example, under the age of 50, and this is already in the guideline, it just doesn't happen. So for breast cancer, there are women under the age of 50 who are at high risk based on a combination of risk factors who are currently not screened, and there will be people over 50 who are at lower risk. That could adjust the interval results for mammography. Similarly for cardiovascular disease and diabetes, currently we're missing people below the age of 40 who are at significant risk based on that combination of risk. And the third key difference is, although some cohorts, and I know I'd be keen to hear more about it, maybe in the discussion cohorts that you have here, we have been able to recontact participants and they take part in future studies. Most of the very large cohorts have not been able to do this. So we've just done our first recall by phenotype study, which I'll come back to at the end. But it has been set up. Everyone that consents agrees to be recontacted to take part in future studies, including clinical trials. And finally, I mean, this is the first cohort which is really large enough that you get an idea of what's going on at the whole population level. Of course, there'll be some biases within that, but it's 10% of the adult population of the UK. That gives us an insight into what's going on at the whole population level. Something like the Health Survey for England, which many of you are familiar with, tends to have a few thousand people. So it's a representative sample that gives you a good idea of like prevalence of risk factors and things, but it doesn't really tell you anything about geographical variation or variation by age, ethnicity, etc., because the sample size just isn't big enough. But it also allows us to look at the impact of, for example, government policies or local authority policies at the individual level. Again, it's usually quite difficult to do. So these are 4 the key aims of the program. And in terms of the first one, obviously the types of research people will do, we hope that will be as broad as possible. But that will depend on people applying to use the resource. So all of you here are researchers, so I hope you'll apply to use it as well. So as I said, for those of you who are already participants, you'll know this, but just in case any of you are not, you join the program online, so it's a digital entry point. Currently, we don't have a means for people to join non-digitally, but that may be possible in the future. After consenting, you fill in a questionnaire, and then you attend an appointment in one of our either mobile units. There's a picture of one of the mobile units in a supermarket car park or pharmacy, or places in the shopping centres as well. You have some basic physical measurements taken, give a blood sample, and provide consent for linkage to health-related data sets. That's mainly NHS data sets. and to be recontacted for further studies. Now, of course, well, something we're familiar to all of us in the UK, just although it has limitations in relation to how we are able to, excuse me, treat patients in long waiting, etc. It's a fantastic resource for research because we have a single healthcare system which runs from cradle to grave, and so that really is very powerful for the both retrospective and prospective tracking of our participants. Combined with the genetic data, physical implementation, questionnaire data, that gives us a uniquely powerful and really unique resource globally to be able to do this. The HDRS, which is going to start soon, the Health Data Research Service, which some of you would have heard of, is a complementary service. So it will have data on the whole UK population. It'll bring together all the NHS data sets, including primary care, which up until now has been quite difficult to do. Of course, what it hasn't got is some of the critical information that you get from the questionnaires in terms of people's lifestyle and habits. It's often not well recorded in standard NHS data, and certainly not in younger people. And of course, it doesn't have the genomic data either, which is important for many diseases. Currently, we're using a genotype array. We don't have funding for whole genome sequencing. To do any test on 5 million people, of course, it's very expensive. But genotype array is just about affordable for us to do across at least 3 million of the cohort. So this will be a very helpful resource, we hope, for researchers working in this area. But it does have some limitations compared to whole genome sequencing. It's a custom array that we developed with a working group of experts in the UK mainly. It has got some additions which are not on the standard array, so including the ACMG and ClinVar sets, polygenic risk scores, and some markers for pharmacogenetic research and for blood type, which is collaboration we have with NHSBT. We're working with genomics for the work on infiltrating ancestry and polygenic risk scores. So that's the kind of background. Now I'll go through a brief status update to where we are. So we launched recruitment in October 2022. One of the things we learned from biobank experience is that if you only have, and there were good reasons for this, so it's not a criticism at all. They had 22 recruitment centres for the 500,000 people they recruited, but it meant that people had to travel up to 25 miles to attend a recruitment centre. And that inevitably leads to a degree of bias in terms of people that are willing to travel. And they also told people when their appointment was. It was an interesting strategy. But yeah, for those of you who are familiar working with the biobank cohort, there are significant kind of biases in that cohort. Well, one of the ways we thought we can help with that is to make it much easier for people to get blood samples. So instead of having 22 centres, we've had over 500 across the whole of the UK now. And to really make it as easy as possible for people to attend their appointment, we also provide nominal compound reimbursement so people aren't excluded on the basis of kind of financial hardship. And that actually has enabled us to recruit a much more representative or diverse cohort, but also much faster. So there are 4 areas we're really focused on, and these are not exhaustive, but the 4 main areas were geographic diversity. So again, very few cohorts, or I don't think any cohort historically have been able to recruit across the whole of the UK, even as a biobank recruited across about 40% of England, Scotland, and Wales. It didn't recruit in Northern Ireland. The exact cohort, actually, I'm not sure. Maybe someone in the audience knows, but again, I think it was in the UK, and it's very as well. Yeah. But I haven't seen the geographic diversity of that. But it certainly has age diversity as we do, because our study is also open to all adults, but basically there's very few cohorts globally, particularly with blood samples that have people under the age of 40. I think diversity, of course, is important. And a particular focus for us was on socioeconomic diversity, well, given the worst outcomes, as we saw at the beginning, certainly in the most deprived groups. So we hope by having this much more representative cohort that we can undertake research that will actually help to reduce inequalities. There's always a risk with this type of program that actually increases inequalities because you only get very well taking part. In terms of genetic lack of genetic diversity, this is a bit out of date now, although the pattern hasn't really changed. That the vast majority of data we have globally is still on European ancestry populations, even though obviously a minority of the world's population. We realize it's slightly out of date now. For example, the UAE, United Arab Emirates, Abu Dhabi in particular, has now recruited, I think, 1 million people into the MRI genome project, which before I was at IEU, that's the program that I had helped set up when I was based out there. So that's a significant contribution. And before they actually had the lowest representation of kind of major populations. And there are other initiatives which are not reflected in this graph, which goes up to 2019, but the pattern is still the same. The vast majority of data is European ancestry populations. Okay, so first, how have we done in relation to overall recruitment? You can see here really an unprecedented response from the British public, particularly, as I said, in terms of giving a blood sample. It's not easy to get blood out of people. But yeah, over nearly 2.8 million people have joined the programme, of whom 2.1 have completed their questionnaire, 1.6 million have given a blood sample. And that's really, as did not happen before. And you can see on this, hopefully it will work, the kind of geographic representation of the cohort. Which, again, because it's a digital entry point, anyone can join in. There's actually very few people across the UK who don't have access to the internet. It's like 99% they have coverage now. So it's not really, people are very rarely excluded because they can't access the internet. There are some other reasons why people can't join in terms of ability to use digital tech, which we will investigate. But yeah, I mean, you can see hopefully on the left are the people who have consented, on the right are the people who have done the question and given a blood sample as well. And really very good coverage. I think this may have been done just before we opened up recruitment in Northern Ireland, so not as many people in Northern Ireland, but we do now have clinics in Northern Ireland as well. And it doesn't project here, but we have got people, for example, in Orkney and Shetland as well as rural areas that have really never been able to take part in this kind of study before, and a very significant cluster around Bristol as well, as you can see. So I think in Biobank you had maybe the highest response rate, or one of the highest response rates in Bristol. So we haven't looked at that level in local region. They have very good overall coverage. This I usually show for international audiences and to UK ministers to illustrate that the UK is much better than America at these kinds of studies. So there's two other large programs globally that apply to recruit 1 million people with blood, and the Million Veterans Programme, which is obviously veterans, the All of Us Programme, and then Outreach Health, which, as you can see, has been able to recruit much faster and actually at much lower cost, so about 1/10 of the cost of the All of Us Programme. Yeah, we still are world leading in large cohorts and smaller cohorts as well, as you're familiar with interest. The reason I say it's the most diverse, I mean, the All of Us cohort, to be fair, is also very diverse, but it's much smaller. So it's about 600,000 people at the moment. But they have got good diversity, both ethnically and other respects as well. Our ethnic diversity is mixed. So for some ethnic groups, actually, we have either, as you'd expect in terms of sense of representation, some even slightly higher, for example, the Chinese and mixed group, and some are lower, like Pakistani and Bangladeshi. And that's the biggest driver of that is age. So the ethnic groups which are younger, which is particularly Pakistani and Bangladeshi, they're about 10 years in on average than other ethnic groups. That's really driving that lower response rate, and partly deprivation as well. They're also the two most deprived groups. But there are some trust issues as well, so particularly amongst Black African, Black Caribbean populations, for good historic reasons, people are less likely to trust programs like ours. I don't know if you found that in your own cohorts here as well, but we've seen that obviously there's additional work needed to explain to people why these kinds of programs can be helpful to them as well. And in general, I mean, we don't use this terminology, but the kind of inverse, we talk about the inverse kernel, but there's something similar research, the inverse research law, that people are most likely to benefit from research law, so the least likely to join. So we are seeing a bit of that in our future health as well. In terms of age, maybe the next one is actually slightly clearer. We have a very large number of young adults now in the program, so over 600,000, 18 to 40 old, which is by far the biggest in the world in that age group. So for obesity, mental health disorders, and actually many other conditions which start in that age group. We've got the first opportunity, I think, ever in the world to really understand what's going on for those disorders in the right age groups. By deprivation, again, we're not representative. I mean, 12.8 would of course be 20%, but in terms of absolute number, that's actually quite large. So over 300,000 from the first quintile. Comparison, for example, most previous cohorts have not been able to get more than tens of thousands from that second quintile. So I hope again for the first time we can get a better understanding of what's going on in those most deprived groups. And there are differences. You may have heard something called the poor gap. So if you look at East London, for example, it now has, it used to have very low life expectancy. So if you look at Blackpool, which now has the lowest life expectancy in the UK, and Tower Hamlets, like 30 years ago, their life expectancy was similar. Blackpool hasn't really gone up much since then, and there's a shocking kind of statistic that men in Blackpool now have lower life expectancy than men in Bangladesh, one of the poorest countries in the world. But Tower Hamlets and other parts of East London, their life has increased a lot. So it's now above the national average. And what's driving that is a good question. Some of it's definitely the ethnic element. So there's something sort of the healthy migrant effect. So people who move to the UK, of course, have to be healthy on average and their countries of origin. But it's not the whole explanation. And particularly for the Pakistani and Bangladeshi groups, they didn't have to necessarily have jobs when they moved in. Until the 1980s, anyone from the previous kind of British Empire could move to the UK. So it wasn't just a healthy migrant effect. There's something else going on, which I'm keen for us to explore within our future. Okay, and in parallel to recruiting a lot of participants, we also try to make the data available to researchers as quickly as possible. Because if we wait until we stopped recruitment, obviously that would have been a missed opportunity for you to start looking at the data. And it's already a very large data set. I think you can see I won't go through all of the rows here. I'll just mention a couple of them. So the dispensed medicines data, this is really the first large cohort or consented cohort with primary care data. It's not the whole primary care data, of course, but it's the dispensed medication, which is quite helpful, at least in terms of diagnosis. And later this year, we are hopefully, although of course what happened with Biobank last week is not going to help, but so there is a directive from government now that we can apply to access the primary care data. Historically, you can only access secondary care, death and cancer, and various other registry data. But now we can apply for primary care data ourselves. Biobank and Genomics England have the permission to do so. But it'll take a few more months before we get the data, hopefully by the end of the year. Yeah, on genetic data, although we have bloods on 1.5 million people, it takes obviously a bit more time to both genotype them and impute and get them into the data set. But hopefully by this time next year, we should have kind of at least 1.5 million on all of these data sets, including the genetic data. So something for those of you who work in genetic data field or genetic epidemiology to hopefully look forward to. I mentioned earlier that we didn't want to get a cohort for the worried well. I mean, I'm not going to go through all of the metrics that we have, but if you look at, for example, we used to measure cholesterol levels, and half of the cohort roughly had high cholesterol. Blood pressure we still measure, roughly a quarter of the cohort has high blood pressure. On most risk factors, our cohort is not much healthier than what you'd expect from something like Alzheimer's in England. On self-reported diagnosis, again, there's a lot of prevalent disease. As you can see, these are absolute numbers as opposed to percentages. But if you compare the percentages, they're not much lower. They're not going to be exactly the same for obvious reasons. But it's not a worried well cohort. There's a lot of illness there. And that's what we wanted, because we want to understand what's going on with the population. But yeah, pretty much whatever disease you're interested in, we will have certainly prevalent cases now and in the coming years, as I'll show you a bit later on. Many infinite cases as well. Now, where we are somewhat limited compared to many other cohorts is the kind of depth of phenotyping. So going back to my point about anything on 5 million people is very expensive today, particularly any blood collection or physical measurement collection. So we're focused on kind of the very minimum that we could usefully collect, given the budget that we have. But also, this is different. Our field is not just a research study for etiological discovery research. And we want to demonstrate things that could be implemented in the NHS at scale. So you could see our future health as a pilot for the whole country, very large pilot study. But what we've measured at baseline, as you can see on the left-hand side of this, is not that expensive to collect data through a questionnaire, do a genotype array, and link to NHS basic clinical measurements. We have established a very efficient model. I think this could be done for probably £100 per person, even within the NHS. And that's something that could realistically be done across the country. And that's important, as I say, because if you've got measurements like MRI scans, no one's ever going to give everyone an MRI scan. So we've concentrated on things that can be done on everybody. The next, what's in the middle column here, I mean, again, this doesn't cost us anything really to link to these additional data sets that they already exist. The primary care, of course, is the key one here. So there's many diseases, of course, that don't present to secondary care. And that will be a very significant breakthrough, actually, as we saw during the pandemic, when it was possible to link to primary care data really for the first time, how helpful that was to understand the etiology and epidemiology of COVID and who was getting worse outcomes. And then in terms of what's on the right-hand side here, this is obviously a non-exhaustive list, but there's a few things which we are keen to facilitate soon. So the follow-up surveys, we haven't done any follow-up surveys yet, so we're confident based on first contact study that we've done that there'll be very good response rates to that. Big linkages, as I said, are more straightforward, although what we're planning to do, and again, I think you have some experience of doing that here, is to link the administrative data sets, so education, work, PWP, etc. That hasn't been done on this scale before, but given the importance of social determinants of health, would be, I think, a missed opportunity not to do that, but that would need an additional consent for us to enable. Cognitive function is one of the areas we've been working on. You saw the age distribution. We have, over 1 million people above the age of 55 in the cohort as well. So good opportunity to understand how cognitive health changes over time and to identify people at risk of Alzheimer's and the dementias much earlier. Wearable data, again, we haven't been able to do this yet, but it's in terms of, for example, measurement of physical activity. Questionnaire data, of course, has significant limitations, and everyone pretty much has a smartphone now, and that gives us fairly good data, at least on basic step count. And a lot of people, again, the costs are coming down now. I mean, I've started wearing one of these rings myself now because just to test how good they are in measuring. I mean, step count is not very different to what you get from a phone, but sleep is much better, for example. And again, the costs are coming down. So whether it's I wouldn't say it's nothing against Apple, but these are too expensive for everybody to get. But there are some of these bands now that you can get for like 30-40 pounds, which are affordable, necessary for everybody. But we will focus on things that can be routinely collected on people's smartphones anyway. I think soon it might be possible to use a smartphone to take a picture of your retina as well, which will be helpful, say, for things like what you get currently from a CT scan. I think the technology is progressing quite fast, and that gives insights into cardiovascular as well as eye health. Then finally, and this is the most expensive part of this slide, the additional omics. So if we move to whole genome sequencing, methylation, proteomics, etc., that is really very expensive and beyond our scope at the moment. Although we hope that we will be able to gain that additional funding. The marginal cost of doing this obviously is much lower in an existing cohort than starting from scratch. So hopefully there will be an opportunity, even if it's on a subsection. So given, I mean, for example, if we said we're only going to do it in certain non-European ancestry populations, that would be helpful in this, the underrepresentation we have there, or in modified populations because of the lack of data we have there. So we can do that. So again, I won't go through all of these, but this is, it's a relatively short list actually. There are hundreds of research opportunities within the cohort for researchers. The power of this, and I think Biobank has really demonstrated the power of opening these resources up to everybody. That collective wisdom of all researchers across the world, of course, is much greater than if it was under the control of one academic group. So there'll be many questions we haven't even thought of that people can answer using the resource. Let's mention a couple of them. So pharmacogenomics, the kind of evidence base in some ways is already there to improve prescribing both in terms of efficacy and safety, but we don't have the means to implement it because, of course, people don't have data readily available, and even if it was available, would GPs be able to use it or pharmacists routinely? But I think we can demonstrate that within our future that would be possible. The AI model is certainly not my area of expertise, but given the amount of data that we have and the complexity of the data we bring in, there's additional data sets. I think we recognize the need to use AI machine learning to really make best use of the resource. And then the final point there about the less common or rarer diseases. So we produced a table which is in our protocol for those of you who have seen our protocol. It's one of the appendices. So this is just the selection of diseases from that table, which I just picked out some of the diseases across different areas, which I would say they're not rare, but they're not common enough that we've been able to really understand either etiology or how to prevent them today. So just to mention a couple, I mentioned pancreatic cancer already. Ovarian cancer is another good example of significant mortality, but not really well understood. Polycystic ovarian syndrome, endometriosis, and other kind of female reproductive health conditions, again, not well studied in the past because there are not that many cohorts with large numbers of women of reproductive age. chronic fatigue syndrome, Parkinson's disease, multiple sclerosis, MND, in the neurological space, and many psychiatric disorders, including schizophrenia and bipolar. So it's a little bit small, but what this is showing that with a cohort of 5 million people, within 2.5 years, which is not a very long time, but certainly within 5 years, you'd have very significant numbers of incident cases for all of those conditions, really for the first time ever. So that should hopefully both aid to understanding of etiology, but as also to run interventional studies. Okay, so just in the last few minutes, as I said, you can access the data for research now. If you go to our website is not ideally set up for researchers because it's set up for participants, but there is a link from the participant website to our research website where you can get more information about the cohort. But we don't have as good a, for example, showcase of the data as the All of Us program or even Biolink for that matter. So to really understand what's going on with the data, you will have to access the data from the TRE. And it's not very expensive for academics. I think it's £9,000 for academics. It's much more expensive for industry. So if you are a large pharma company, now you have to pay 50 billion to join. But academics are trying to make it accessible to everybody. These are some of the projects which have already been approved. There's a list of all of them on the HPI UK gateway. Again, I won't go through them, but I'm happy for these slides to be shared, by the way, with the group if people are interested to see them. But you can see most of the applications I've had so far are really looking at a combination of genetic and lifestyle and environmental risk factors for a range of diseases. Pharma companies, of course, are more interested in target and drug discovery. And academics tend to be more on the epidemiological research side. And the last thing I just want to mention is our clinical research recruitment service that we launched earlier this year. So again, our Future Health is not just a data resource, it is a resource for particularly clinical trials. So all of the participants have consented to be contacted for this purpose. We're nearly 2.8 million now. We're confident we'll get to 5 million. That's a very large pool of people who are willing to take part in additional research studies. There's a main advantage of this is, of course, that they're consented, so your responsibility to expect to be higher. But also we have quite a lot of information about them. So in terms of pre-screening, we are able to identify people for clinical trials much more efficiently than the existing resources. Something like CPID can do it, but they don't have as much information because it's based on routine healthcare data, which is, and this is quite a lot of information. And certainly if you want to do a by genotype study, you can't do that in existing NHS resources. In IEU Child Bioresource does do that. I think probably some of your cohorts here do that as well. But in terms of a UK-wide large cohort, then it's really the first time we do that. We've only done one study so far, which is a pilot on esophageal cancer prevention. So we agreed to help. This is the best for study for those of you who work in this area. So it's using a new diagnostic method for early detection of actually not esophageal cancer, but Barrett's esophagus, which is a precursor to esophageal cancer. And you can see kind of validating our assumption that our response rates will be much higher than you'd expect from the general population. A really very big increase in response rates, which is important for us to demonstrate that all types of clinical trials, we have an interested cohort of people in these types of studies. Okay, I think this is my last slide. It's a quote from the Millennium Premier, which is on our scientific advisory board, as it's also Nick. So thank you to all of our advisory board members who've been very helpful. He talks about precision medicine. And for me personally, of course, I'm interested in this, but I'm more interested in what I would call precision health. So medicine, of course, is treating disease. Health is much broader, even a good health, preventing disease, etc. And that for many of those things, genetics is obviously not that important. But the good thing about resource like Future Health is that it's useful, hopefully, to all of you, especially in different research areas. And so I will stop there and happy to take questions or comments.
Thank you very much. Thank you. Very interesting talk. Sorry, on a very impressive study. So yes, we've got time for questions, so we can open it up to questions I've got online on info. Do you have one?
I was just wondering if you've got any, like, what measures you have of inequalities in your study. I know that you said you haven't got education at the moment? Are there any other measures that you have?
So in terms of data linkages, we don't have the linkage to education data or DWP or TMRC because we don't think that's covered by our current consent to the health-related data, although in health-related, most people wouldn't understand it in that way. So we need to apply first to get record approval and then to get consent for individuals. But what we do have from the questionnaire is information about people's educational level, current employment, income, etc. And most people have filled in the income question. So if you go to the data in our theory, you will see that information. So we have got the data I presented on information is based on postcode and IMD score, which is not perfect, obviously. So that should be combined with the other data to really understand the deprivation within the cohort.
Yeah.
But based on income as well, we have got a very broad range of incomes across the cohort.
Yeah, that's the one they take sort of need.
Exactly. Yeah, and education as well. As in, it's not fully representative as you'd expect, but there's enough people from very low incomes, lowest level of education, etc., that we should be able to look at difference between those groups and within groups as well.
I think that was really helpful. I was wondering if you could answer two questions. One about the feedback to participants and how do you handle what happens after that in terms of accessing healthcare and not putting too much pressure on the NHS. And I was also wondering, with the current setup, is it possible to use the genetic data to identify families?
So on the first one of the reasons we haven't given much feedback yet is because of that very reason. NHS, of course, is under a lot of pressure dealing with sick people, and we understand that if we identify people at risk of disease, and particularly primary care, then under a lot of pressure, but that will just increase that pressure. So we're working closely with NHS to plan this over the next few years. So the first project we're planning to run is on integrated risk scores for cardiovascular disease. That's relatively straightforward because there's already the NHS health check program in England. So people are used to dealing with that, so it'll be a kind of incremental step. In the first kind of half of the program, we used to give people back their point of care test for cholesterol. It's a very simple test, and GPs know how to deal with it, of course. But even that, some GPs did complain was unhelpful because of the additional pressure. So going forward, we're being much more careful about what we feed back to participants. But ultimately, we have to do that because otherwise, you won't be able to answer those research questions. And the NHS understand that, and that's why it wasn't the NHS 10-year plan. That's so when we started, although we've always been running partnership with NHS. It wasn't as joined up as it is now in terms of what we're trying to achieve. Your second question, so of course, looking at the genetic data within the cohort, it would be possible to identify families. We don't ask people if they've got relatives in the cohort, but we would be able to also identify them through the genetic data. And because we've got this very broad age group, we already have, I know this one case of 3 generations, but my son's part of it, my mum's part of it as well. And I'm sure there's quite a few, families like that where you've got siblings, different generations. And with the adolescent health study, one of the things we're keen to explore actually is whether we can recruit participants into that study from our study, because that also would be very powerful, because then we'd have trios with both parents and children. So yeah, there's that, but that is possible. To answer your question.
I have a question in the room now. I'll take 2 at one.
Sure.
My understanding is that there's a reduced rate if you're funded by Cancer Research UK, and I was just wondering if in the future there are plans to extend that to other charities, and it kind of links to Richard's question about student options.
Yeah, so BHF, Cancer Research UK, there is a discount. MRC funded researchers now, all your fees covered by MRC as of from this year. There's a new scheme that's being launched by the MRC. They'll cover the cost of all MRC researchers to access our research. For students, we don't currently have a reduced rate for students because most students, in terms of those that apply so far, have been part of another application. So the head of department applies and then it opens up the resource to students within the centre. Whether we could have a separate scheme for students, we could, but we haven't yet. What we did have last year was what's called an early adopter scheme, where there were no fees at all. So anyone could apply and then get access for nothing. So yeah, we don't want it to be a barrier. And a bit like Bliming, I'm sure at some point we will waive the fees for low income countries. They haven't got to that point yet, or low income countries.
Got another question online, which was relating to the data breach from UK Biobank. So question on how our future health sort of protect against that. I suppose the importance of participant trust in doing it.
Yeah, so I mean, UK Biobank was set up in a different time, of course. I don't know what was done without the days, but I assume like Biobank, TRAs didn't exist, and so you were able to. The only way you could analyze the data was by downloading it onto your system. So for the first 12 years, I think that was the system for UK Biobank. So a lot of the Biobank data is already out there. People have downloaded it. I'm sure you've got a copy here. Now, a couple of years ago, they bought a new system like ours with the TRE. So from 2024 onwards, you can only analyze the data, or at least the new data, by analyzing within the TRE. Our system was set up on a TRE, as I mentioned. So from the beginning, it's never been possible to download data. So you can only export the analyses of the results of the analyses that you do within the TRE, and also we have an airlock. So we have a manual check before any data or any results data leaves the system. There's a much higher kind of level of security. What I didn't know until last week was that biobanks still enabled, although in the terms and conditions you're not allowed to download the data, they didn't have a technical way of stopping it. I should have known that, but it seems a lot of people didn't know that.
Well, the breach came through the RAM.
Yes, exactly.
The alarming thing.
No, I know.
Some people have accidentally downloaded the data. You press on a button, download the data set for you.
Really? Okay. The fact there have been 198 breaches according to someone not said it over.
But none of them, as far as I know, try to sell it or to
I was going to say they couldn't sell it for much anyway. They can get it like that. So it wasn't very good kind of business.
You had any queries from participants about feature not?
Not that many. I mean, out of the 2.8 million, some people have withdrawn. So roughly around 50, I think. Out of 2.8 million, it's a very small number. I mean, it's not helpful, of course, because it reduces trust. You know, we're on the verge of being able to get primary care data. I think it will potentially delay it a while. But yeah, we have a very different system from the beginning with our future health. Of course, we're not complacent. In fact, we spend a lot of time, effort, and money to protect the data. And because a data breach for us now is by far the biggest risk to the program because of this effect on trust of participants and the broader community.
Right, really great talk. I guess on a kind of scientific level, when you have something like UK Biobank and you do a GWAS of LDL cholesterol, it's very clear getting the genetic effect of LDL. When you start running trials within cohorts, you then get a combined genetic effect of LDL and entering the trial. And that might be tiny in the many trials, it might be nothing, but it might actually be really big. And you see that if you adjust for statins and UK Biobank, you get crazy effects. And is that something you've sort of thought about, like the flag, this participant entered a trial in this phenotype or something?
So it's not something that I've personally thought about. Whether the SAP is discussing it, I'm not sure. But it's a good question. Yeah, to be honest, I don't know. We haven't done any trials like that yet.
No, yeah.
So when that comes up, it'll certainly something we'll need to think about.
Mm.
But yeah, I don't think to answer your question, honestly.
Another question from the room, and then it's the one online.
Yes. Can you tell us a little bit about any ongoing or planned interventional or early detection studies in mental health?
So we've only just opened up interventional studies, and it's only been there for 4 months. And there are clinical trials planned on mental health disorders. And we do have plenty of people with prevalent disease, and these tend to be, of course, chronic conditions. I'm particularly interested, as I said earlier, in digital interventions that might help both for treatment and prevention of mental health. We haven't had any applications for that yet. I hope that they would come through.
How do you imagine the cohort would start interventional studies? Is it a platform for recruitment, or is there any other ways?
It's a platform for recruitment. Yeah. So, for example, I gave with esophageal cancer, the entry criteria for that was actually quite simple. It was people that had a history of heartburn or indigestion, and which we have data from that questionnaire. So we can identify those people, and then we write to them and say, would you be interested in taking part? So for something like mental health disorders, we've got obviously prevalent self-report. We also have GAD7 PHQ-9 questionnaire data on 2.1 million people. So that's another way we can identify people either at high risk or with likely depression and anxiety disorder.
Do you have any online platform or infrastructure that can be used to deliver intervention, or would you expect studies to set those up?
Not yet. And we probably won't do that. We would almost certainly, at least in the near term or short term, rely on researchers to come to us and say we have developed a digital intervention that can be delivered. Some of these already exist, as you know, but I would say they're not very well evidence-based. So we would say if you want to run a study using our participants, then we can facilitate that.
There's a question from Brian in line regarding plans to collect imaging data on composition measures.
So we have discussed that, and there's different ways of doing it. Plus, Biobank, when they did it, and so they did in the UAE, a lot of it's based on kind of bioinfluence or DEXA scans. They're relatively time-consuming and costly because people have to come to a clinic. A lot of this can be done at home and using smartphones. I don't know how good it is compared to gold standard measures, but people tell me that it's good enough. So that would probably be our first way of measuring it, is through things that people can send themselves. So either through pictures or software that analyzes body composition through a smartphone. But I think what we will do on a subset is to bring people back for a series of measures, like a number of different measures. Say, probably not as comprehensive as Biobank, that'd be really quite expensive. But additional samples, urine as well, for example, microbiome, as well as a set of physical measurements and repeat bloods. So if we could do that on 10%, that'd still be 500,000 people, which would be very helpful. If we get the funding, we would like to offer everyone to come back every 5 years for that kind of thing. But in this, I think that's going to be difficult to get that level of funding. What we will do for everybody is give them the opportunity to update exposure data remotely for as many things as possible.
Nick and then Jim.
I just want to, given it's a question more about careers and experience, given the audience, and you've worked as an out-and-out clinician, you've worked as an out-and-out epidemiologist at Phil, you've set up studies like the one in the UAE, and now you've been involved in this substantive enterprise, which involves all sorts of different stakeholders. What are the hallmarks about our future health as a job now that stand out? And is it more exciting than just being academic, or is it worse than being clinical? Do you get a foot into industry, and if somebody wanted to do this type of work, is it something that's sort of appealing? I mean, have you enjoyed it?
I do enjoy it. Yeah, I mean, our future health as a project, I would say, is a once in a generation opportunity for the country and to an extent globally. And for me as an individual, I see it as a once in a lifetime opportunity. And it literally does come about once in a lifetime. But as you say, I have gone through a probably atypical kind of career trajectory, having started as a clinician, then as a maybe more typical academic, and now I'm more of an administrator, to be honest, as CEO. It's not that I have to be CEO to run this project. I mean, Biobank had that model where Rory was both CEO and principal investigator. When our future health started, I was the original CEO, and my predecessor, although he had a research background, was not, you would say, kind of typical academic epidemiologist. But it's not necessary for someone running our future health to be an epidemiologist by background. I think for me, it's helpful to have both a medical and epidemiological background to really understand the kind of value and power of this resource, and to be able to talk to multiple stakeholders within government, academia, NHS, health systems, etc. And if any of you get an opportunity like this in the future, I would highly recommend it. But in practice, of course, this kind of opportunity doesn't come around very often. But what I would encourage people, particularly medical students or doctors, the bit I understand best, is to encourage you to go into research, because the numbers of doctors going into research now has decreased quite a lot over the last few years, and the numbers, particularly in general practice, are like 2% of them, like a tiny proportion, that go into research. But I would say it's made me a much better physician doctor by doing research, and I think having a medical background gives you a different perspective into the importance of the type of research as well. And for the non-physicians, again, I don't know, again, you can tell me about Bristol, how it works here, but the collaboration, I've spent most of my career in Oxford, where there is, I think, very good collaboration between the clinicians and non-clinicians in ensuring we get the best out of these types of resources.
Final question.
That was such a cool question. I just had a technical question. But I think it's so exciting to have a diverse club. But there's a sort of a double-edged aspect to that, in the sense that there's a lot of potential weaponization that can happen if it looks like effects are different across different ancestries, like biological essentialism and that sort of thing. And so, I think the chip design committee spent a lot of time trying to emphasize that the genotyping array needs to be designed to avoid parity in performance across ancestral groups. Have you managed to like look to see if that's true? Like if there's not differential measurement error and imputation across?
So we haven't been able to look at that yet because that shape is not currently on our TRE, and it will be there from May. That'll be the first opportunity, I think, to understand that better. I mean, it's certainly a challenge and a risk. I suspect because the cost of sequencing is coming down significantly, that we will sequence the non-European ancestry people within the next few years. That will help. So things like polygenic risk scores and array-based technology, there is a bias definitely for non-European ancestry. But they don't perform as well in non-European ancestry populations. So we have an opportunity hopefully to improve on that within our future. I'm not a genetic epidemiologist by background, so what the answer I'm giving is kind of high level, but there are people within our group that could answer your question more comprehensively.
Thanks everyone. Oh well, that's our time, I'm afraid. So yeah, thanks everyone for coming and thanks for those questions. And yeah, if we could all just thank you one more time for
Yeah,